So next we'll move to the magic bullet of MIGS, iStent and KDB, followed by myself. There are three more eminent speakers. Can I have the slides? Yeah, thank you. So I'm Dr. Prasanna Venkatesh. So I'll be taking you through the MIGS video-based deconstruction along with a four-dimensional live training that we have for people who are interested in it. And these are the objectives of my talk. I have divided it into 6 parts. You can see that this is what I'll be covering it in this particular session. And my journey started in 2019 in the World Glaucoma Congress, where I was lucky to actually get myself trained in MIGS when I was a fellow under my mentor, Dr. Satyan sir. And it's an ongoing journey. And the goals of the MIGS and the MIGS has been extensively dealt by detail in Amit and my previous speakers. And this is one of my publications in IJO where we'll be talking on this in this particular video-based session. And also Dr. Murli sir will be touching on gonio scrubber and SPLAT, which are something new and upcoming, along with the aqueous reduction procedures as well. So we have the patient selection criteria, which was exclusively covered. We start with mild to moderate glaucomas, and to touch on to that direct gonioscopy point, I also use a pencil marker. You can see that this is before and after. So these are some simple tricks that really help me get my practice going, where I am not assistant dependent. So I have this marking done with a pen, so that every time when I finish my phaco and send my microscope to the assistant, so that if the assistant changes also, you see that the stress levels are not very great, because he just needs to make sure the marking is connected to the one that we have drawn. So this is a very simple thing that is working well for me. And of course the head tilt of the patient, something that is very important. So no financial disclosure, but I just wanted to show this particular lens, the TVG lens. You can see that it has a clut ring here. So I found this works well in my hands. Just to add on to the point on direct gonioscopy, the Thornton style stabilization ring. You can see that this lens here, which has a lot of clut rings, especially in the initial stages when you give the peribulbar block and the eye is oriented in a different plane, right? Sometimes with the other lenses that are disposable, you don't really get an option to move the eye once you keep the lens. If you try to move the eye once you have placed the lens, you end up losing the angle. But with the Thornton style stabilization ring, I've always felt the added advantage of, you can see that sometimes I use only a simple HPMC. This is a simple HPMC, but see how the docking happens, just like an indirect gonioscopy on slit lamp, and you see how you can move the eye with the lens. This is a blocked eye. You can see that on the right hand side there is a block that has been done. But despite the block, it's actually very difficult to move a blocked eye with a direct gonioscope. But with this lens, what I've noticed is when you do advanced mixed procedures, or when you do a bang or a KDB and you want to go to the extra edge in the left or the right side, I think this lens is something that neophytes or beginners can start their gonioscopy journey, so that you'll gain more confidence as you move forward, where you start performing these handless techniques. And the reproducibility of this are excellent. This is one of my live surgery videos, which I recently got an opportunity to perform in January at Surgical Strike. Right, moving on to the excisional goniotomy, the procedural journey is the 26 gauge needle that we use for a bang for a rexus. Just make sure you bend it the other way, and you go inside out approach is something that I always advocate as a right-handed surgeon. You go anti-clockwise followed by the clockwise direction. Again, as Dr. Madhavi rightly pointed out, identification of the structures is the key factor. That is how you go forward, and you can always keep following up the cleft. As you can see that this is a cleft between, I've just marked the demarcations in a bang. So we did analyze our data, and now we have more follow-up of 6 months to even 9 months and 1 year. And the success rates are quite promising even with bang 2. You can see that, this is a drop in intraocular pressure. These are my own cases, and there is a pressure reduction of one medication to 0.52. So these are some of the mild glaucomas that I started in the early journey. And of course you do have your fair share of failures, and certain observations that I have noticed in 2 of my patients are the patient's visual acuity is fine. Maybe at then we can have the discussion on this. But the 2 patients of mine in a study of around 50 to 60 eyes, I've seen some mild choroidal folds along with the microemphysema, and one of my patients did had a PAS inception, which I have not seen in a KDB case. So again, this is a KDB analysis of the same. You can see the drop in KDB is slightly more plateaued compared to the bang, at least in my hands. And the reduction of medication rate again is quite similar to 1.16 to 0.66. These are the mild glaucomas that I am talking about. And again, the failure rates are quite similar to the bang, but the complications are more controlled and more refined compared to a bang, where you can see the mean reduction in intraocular pressure. I feel KDB group shows a slight mean reduction, which is slightly better than the bang, because I feel that blade is actually more made for that. And day before yesterday, madam also covered that KDB, you get more of a complete removal of the trabecular meshwork. You don't really nick it or open it. It's more like a complete removal of the trabecular meshwork. And AGM reduction shows a similar rate, but the IOP reduction shows a slightly higher one compared to the AGM reduction. So the procedure, so this is an unedited video. I wanted to show an unedited video of the KDB procedure here. I just want you all to notice this particular thing. You can see that the field is more, a lot of having blood. When you place the lens, you can see the centrifugal distribution of the blood. So once that happens, try avoiding taking your gonio. Once you remove the gonio, again a centripetal rush takes in. So that is something you need to avoid. So what are the key points here is your left hand and your left leg. So now I am zooming in with my left leg, and I am now fine focusing again with my left leg. So now I am doing the fine focusing. So this is a 2-minute procedure once you master it. So you can see the length of the video is 2 minutes. I have not edited it, I have not fast forwarded it. Now I am zooming out. So why am I zooming out? I want to identify the main incision so that I can get my KDB blade in. And again I am zooming in. At every point you can see, I don't move my left hand. Again, this is not a Taunton stabilization ring. This is just a eye prism S that I am using. So with the disposable lenses too, once you master, just make sure once you put the direct gonioscopy, don't remove it, just have it there in situ, and then go for the excisional procedures. Your left leg has to work. If you want to move towards your left or the right, you want to find focus. So again, this is a good sign that you are seeing. So once you have started opening the trabecular meshwork, and you can see that a small amount of blood will be there, that is a good sign that the episcleral vessels are actually perfused. And if you have some difficulty, as you can see, I am having some difficulty in the clockwise movement. Just reassess yourself, don't be very quick, just make sure you are in the right plane, and there it is, the procedure is done. It's almost completed in 1 minute 17 seconds after I did the direct gonioscopy. So this is again the completion that I wanted to show. You can always use a Helon GV Pro, no financial disclosure. Again, see how the blood is removed from the cornea. See, now the blood is on the cornea. So I am putting the Helon GV away from it so that you can see how the blood is now getting cleared from the cornea. So these are some simple tips and tricks which are very important when you are doing advanced mixed surgeries like suture gad, where you will have to have a lot of removal of blood when you are going with the procedure. And this is again another simple one for video recording. I am putting some saline on the lens. I am asking my assistant to put some saline. So what I noticed with the disposable lens are, sometimes a good video recording is hampered. When you put some saline, right, the field is again cleared and your video recording quality improves. So this is just an unedited 2-minute video that I wanted to show. So once you master the procedure, how you can really take things forward. So now we have slowly but steadily moved into some of the angles which are more oppositional angle closure. You can see these patients where the root of iris is slightly more highly inserted. But once you identify the right plane, right, you will be able to even get the fall of the iris. As Mohiddin sir was showing in his video where he used a Tanito hook to actually press down the root of iris. The same thing can be done with the KDB as well, where you can see that once you are in the right plane, opening up the trabecular meshwork can also cause the root of the iris to fall back in cases where the pigmented, the root of iris is at the level of pigmented trabecular meshwork. So it really works well. So we also shifted slowly towards moderate glaucomas and select angle closure cases, and we saw a drop in intraocular pressure of -6 from 20 to 14 and AGM reduction of -1.28, and 86% of the 42 eyes are medication free. And this is one of the novel observations that is due for publication in the next issue of Indian Journal of Ophthalmology, where we are publishing a W sign with KDB where there is a complete removal of the trabecular meshwork, and you can see that that is not seen in a bang, which I will be showing in the subsequent slides. So in KDB versus bang, you can see that there is always leaflets that are there which are very minimal with KDB. This is again an animation video made by me, where in bang there are always leaflets that are possible to be remnant. You can see that in the bang scenario there will always be some amount of leaflets which may serve, you can see these leaflets, which may serve as a precursor for future PAS formation or even trabecular sclerosis. Again, this is another novel technique that I used to follow when you want to reach the more periphery. Just give a nick, and I think I learned this technique from some of my colleagues on the dais who has a lot of videos. You can always use ILM peeling forceps, then remove the trabecular meshwork which is overhanging, and you can keep it on a sponge and then demonstrate it. So then we have the iStent G1. In the iStent G1, which is now obsolete, so I'll just show what is the right implantation of this technique. It is a tangential insertion. Again, anatomical orientation is the key. So once you identify the normal plane, place the iStent in a tangential orientation, and once you are in the right plane, you can leave it. Sometimes I have seen scenarios like this where the episcleral vessels here, you can see that just adjacent to the stent, you can see how the perfusion actually starts. So you tend to have fair share of learning curve. These are some of my initial cases 2 years back where I used to search for the trabecular meshwork. You can see that there are a lot of cheese wiring happening in attempt 1, attempt 2. So this is a learning curve that you have to endure, and you have to be patient, and you will always be able to do successfully. So these are some of the scenarios that happens in you when, again, this is one of the cases where cataract was done very well, but then when I went to the iStent, the stent was just not there. So it just dropped in the injecting cartridge. So you need to really know the magnification levels, and you need to have a good amount of wet lab training so that you will be able to manage these kind of scenarios, a drop stent in situ or outside the cartridge. So this was something that I wanted to show because these are very small. It just looks like a fingerprint where you need to really work yourself way through. Yes. So moving on to iStent inject G2 series. So in the G2 series, you can see you will more have an axial implantation where it's more automated, and you need to give a slight dimpling and place the stent, and you can see a beautiful paralimbal blanching between the two stents. Not in all cases, but once we are in the right plane, sometimes the tissue really talks with us and says that we are in the right plane and keep going forward. And you tend to have again a fair share of complications in this as well, where there was a superficial implant. You always have to reassess yourself, place the second stent first, then you'll have an opportunity to reassess, retrieve. And in the initial stages, there were not many videos, and you tend to be over anxious. I forgot to close the trocar. So these are some basics you need to keep in mind. Close your trocar and then take it out. So if you fail to close your trocar, you may again lose your stent in the corneal wound. That is what happened, but all's well ends well. I was able to recover it and then place it back in. So the data of us are coming, and it is very promising. Saiban and myself are going to publish it in the Journal of Glaucoma. It's a multicentric one, and the data is, and 91% of the patients are medication free, and the drop in AGM is 1.8 to 0.27. In iStent and in inject, it is almost 80% of them are medication free, and you can see that there is a slight plateau that we are concerned with, but let us see with more time. This is remaining for 6 months and 9 months. Let us see how we can take it forward. And there are a fair share of failures in this as well, but with more time, I've seen what patients really work, and we are taking things forward. And this is an iStent Inject W that recently came with a broader flange, where you can see that there is over implantation that is avoided. You can see the broader flange that is there in the iStent Inject W, where the more better control is noted, and it serves a much reproducible results compared to it. We have one case published with the urate Zavalia features after a stent injection. So this is one of my publications in IGO where we did have one spike in IOP. The pigmentation was more, I think, hindsight, these are cases we can avoid, where we ended up publishing a urate Zavalia case, which was one particular complication that I wanted to bring to notice. And then this is my novel observation, my dear friends. To summarize the MIGS, this is the publication that is due in Indian Journal of Ophthalmology. Figure B is the Y sign that we are publishing with KDB, and figure C, as Moideen sir rightly showed, there is a remnant with the bang procedure, and you can see more of a bird beak configuration, the magnification of suture gap. Because in suture gap, it is more like opening a piece of paper with a thread, right? You can see that there is more like a bird beak configuration, and the orientation of the angles. I went to Anterion because Anterion has more resolution compared to an ASOCT or a UBM, and we have come up with this. And the other topics, I think the next speakers will be talking on how to combine MIGS, which is also published by myself, where we combining MIGS is another visionary outlook I learned from Anita ma'am. And this is a metaverse that we have innovated. It is a patent protected innovation of mine. We have it with us. Dr. Pavitra, my associate, is there. People who are interested, we are always there to show you this one. We went ahead, we didn't want, the love of MIGS took us more further. Everyone was focusing on simulators for cataract. So we wanted to go ahead and make something for MIGS because we wanted to have a more affordable and a portable and a cost-effective training module, as you can see. Why can't we do something for MIGS so that, because you don't get to practice in a Godse, there are some simuli models that are there. So we have our own holographic simulator for MIGS where you can do n number of times the stent placement in the right plane it turns to green, and you can go ahead and get it done. To summarize, what MIGS is, anti-VEGF is doing for retina, I think MIGS is something that is there, and it is doing something for the glaucomatologist. And these are some of the observations that I have made, and this is a personal observation and a personal take that works well in my hands. I think with more time we'll know better how each MIGS are functioning. With more data, with more randomized controlled trials and more multicentric trials, we'll be taking things forward. So thank you once again for this elite panel for consenting for this IC. I think if I am able to do it, I think everyone here who's aspiring to do MIGS, you will also be able to do. Thank you once again for the opportunity.